is a joint session to celebrate award winners in global health, both for the medical students and the faculty award. And we'll hear from our two winners in just a moment. But first, I want to create again our thanks and to introduce Leslie Lewinter-Suskind and Bob Suskind, who have been the generous donors of these awards. Student award now 8 years, 9 years, something like that. And the faculty, 10 years. And this is the 4th year of our faculty award. And, you know, just thank you both. And they're going to come up and say a couple of brief words. Yes, good. But I just say simply, no. 3 to 5 minutes. But they are role models for us all in not just global health, but how to live life and have fun, as far as I can tell. So Bob and Leslie, thanks again, and come on up.
Okay. It's wonderful to be back. It's very difficult when you get to be my age, having graduated in the, having graduated in the class of 59 from undergraduate and medical school, 63. And in those days when they had these old timers coming back, they looked so old. And then all of a sudden we find that we are the same age as those old timers. But it's wonderful to be back and to see what has happened in terms of global health. When I was a medical student, tell you how important global health was to me. There was one person in the class who did anything in global health, and that was myself. I had the opportunity to go to French Cameroon on a Smith, Klein, and French fellowship. And I'll tell you how important that was. It was important because when I met Leslie as a medical student, she was a graduate student. I met her and I said, gee, we talked on the phone for a long time, every night, but I couldn't get a date until I told her I was going to Africa as a medical student. So I got my first date. And then when I came back from Africa, after knowing her only 3 or 4 weeks, I proposed to her. And she said, okay, you've got a deal, but we have to go back to Africa together. I said, okay, you got a deal. So we went back with the Peace Corps. I was a Peace Corps physician to Senegal, French West Africa. And the last part of the story is this. After being in the Peace Corps, I got a job as a resident in pediatrics and was coming back. And Leslie said to me, she said, why don't we take a year out and go home? I said to her, we can't do that. I've got a job. He said, oh, why don't you just call the chair at Hopkins and ask him? So I called the chair and he said, okay. So thanks to Leslie, we had 1 year where we went around the world, including hitchhiking from Nairobi to Cape Town, including going to Afghanistan and going over the Khyber Pass and we had a fantastic job. Learned a lot, and that was the beginning of our experience in global health. And I'll tell you, I say this to a number of people. Global health is so important. You can make such a difference. And for me, global health, I may get very filled up when I think about this, but I know that I would never have been able to make the kind of contributions that we wanted to make in global health if I hadn't picked the right partner. Right? So anybody who's interested in global health, make sure you have the right partner who wants to do it with you, because I would have probably been a pediatrician in private practice somewhere. But we have seen and done, and our last calculation was 170 every continent, and that's all because there was a global health program Oh, I have one other thing before we sit down, and that is I want to congratulate Glenn and Megan and the whole team for what they have done to make global health a real entity here.
Thank
I'm
you,
sorry
guys.
we took more than 5
No,
minutes.
it's fine. It's fine. Oh, no more, no more. All right. So thank you, Leslie and Bob. Really tremendous. So we're going to take just a couple of minutes to celebrate our first recipient, Papa Quadro Morgan-Asiedu. Papa Quadro is a graduating medical student finishing. He's going to his pediatric internship, as I understand, in a little bit, right?
Yeah.
A couple of weeks, a month. And he's had a really remarkable background. I'm not going to go through it because you can read about it here in the brochure. But I think, exemplary of what we hope our medical students will do. His particular interest, as he'll describe briefly, is really in surgery as it applies particularly in pediatric populations. Just we give the medical student awards out every year. I think this is a really exceptional recipient because of the breadth of what he's done, including his MPH, et cetera, et cetera. So if you have the description, I'll stop and I'll turn it over to you.
Thank you. Okay, good afternoon, everyone. First, I just want to begin by saying thank you again to the Suskinds. Thank you for being here, first of all, and sort of blazing that trail several years ago and continuing to contribute over the years to us. I also want to thank the Center for Global Health because you have been one of the main sort of parts of my educational experience here at Perelman. So my name is Papa. I grew up in Ghana. I'm one of 7 children. 3 of my siblings are here today. My dad was able to join. And, that's Ghana right there, for those of you who don't know. In the upper right corner of this slide is a picture of my paternal grandparents. And I have his picture there for a couple of reasons. One, I was named after my grandfather, but 2, when he was in his 80s, he had an accident where he broke his ankle and he was pruning his mango trees. He had been, he was retired at that time. He had been the school principal and he lived too far away from a hospital to get adequate care promptly. By the time he got to the hospital, they told him, we think it might be infected, you really should do surgery, but, maybe go home, come back. So he had what's called a malunion where his lower extremity healed at an angle. He had a limb length discrepancy and sort of struggled with that disability for the last few years of his life, walking with a cane. This is one of the earliest experiences that sort of underscored to me the importance of access to care, sometimes just based on where people live, and also the importance of access to surgical care. So there's this paper which some of you in the room might be familiar with, which sort of pointed out the fact that 5 billion people in the world and 1.7 billion children lack access to safe, affordable surgical care. It was estimated that 143 million more surgical procedures will be needed to reach our targets. And I want to point out the numbers because some people, the finance people usually only care about the money at the end of the day. They said we needed $350 billion of investment by 2030 to sort of reach the targets. But if we're able to sort of invest this small amount of $350 billion, we will prevent the loss of $21 trillion. And so it's actually an investment that makes sense, even though it's a big sort of scary number. There are several things you could touch upon. There's a WHO health systems framework. I have 5 minutes, so I can't go into all of that today. But I'm going to tell a couple of anecdotes, or maybe one, that touches on 3 key aspects that I think are very important: capacity building, medical products and technologies, and then effective financing. So the man over here on the right is called, in the US, Dr. Ohene-Babu Achieje in Ghana. He's called Nana Prof because he's also a chief. And he is Ghanaian. He was born in Ghana, came to the United States for his education, did an orthopedics residency, and then ended up becoming the chief of complex spine deformity at the Hospital for Special Surgery in New York. And because of his passion for global health and surgery, decided, I'm just not going to sit in the United States make a bunch of money as a private practice orthopedic surgeon and, live happily ever after. Over a period of 20 years, he established Focus, which initially was an organization that was just committed to improving access to surgical care. And in 2012, he actually opened up this hospital, which was built right in Accra, first of its kind, really, I believe, in West Africa. And they provided not only orthopedic care, but sort of other kinds of care. They have a sort of family medicine, neurology. They have a really robust radiology center there as well. And the reason I mentioned this is I met him right before medical school and got to go back again during medical school to spend a bit of time. And I saw what we need in global health, capacity building. Dr. Boache made it a point to train local talent. We have a big problem with brain drain where people finish medical school in Ghana and Nigeria and Tanzania, and for valid reasons will move across the pond to the United States, to Europe, because they can earn more money, because there's more financial stability. He said, I want to pick people who are here, who care about providing care in our country and train them. So he's trained several orthopedic surgeons and neurosurgeons, people who are going through orthopedics residency, get to rotate there. And so it's a really remarkable thing that he's done with regard to capacity building, because all of these surgeons are staying in Ghana. And just recently, I believe it was earlier this year, they actually opened, there's another surgeon who opened a similar facility sort of right next to him, which they call the West Africa Institute for Special Surgery, which will have like other surgical specialties, sort of in that same vein. So I think that sort of emphasis on capacity building is something that we're going to need. He also brought so many new medical devices and innovations. Spine surgery is complex. You need so many implants for the spine, even if you're doing sort of run-of-the-mill like knee replacements, some of those implants are just not accessible to the average person. And because he was able to leverage the network he had sort of built in the United States through HSS, through the Spine Society, he has been able to do wonders in terms of advancing orthopedics care in Ghana and West Africa as well. The third bit is the financing. He is a spine expert, and he actually did a lot of surgeries on kids who grew up with some kind of advanced scoliosis. Maybe they were in a rural area, people just call them a hunchback and sort of left them with their deformity. He was able to take care of them. They have an interesting model where it is a private hospital. At the end of the day, you sort of have to hit your bottom line. So the patients who can pay do pay, but they have a sort of charity arm that will take care of patients who come from maybe more impoverished resource challenge sort of backgrounds. But it's difficult. And while I was there, one of the things that I discussed with the current CEO is that during COVID, a lot of the sort of like financial donations that came from donors just went down because, funds got diverted elsewhere. But I think that, people like this who are champions, local champions, he has a dual identity because he was born in Ghana, came to study in the United States, but went back because this is something that he's passionate about. I think we need more of this. And in fact, the person who is the current CEO is an anesthesiologist that he sort of mentored from her early days. It's not often that you find a female CEO of a surgical center like this who is an anesthesiologist. But I think this speaks to the kind of passion he has for capacity building and really empowering local champions, as opposed to saying, let me just call my buddy from some orthopedic hospital in the United States to come run it. Speaking more about financing, one of the things I also got to do during my MPH was, during my time here, is I did an MPH at the Harvard School of Public Health, and we got to work with the Harvard Health Systems Innovation Lab and the Global Surgery Foundation that partners with governments to strengthen surgical systems. It's hard work convincing people that surgery is important. Usually, it's the way they describe it to me is this: if you have a picture of a 5-year-old and you say, this is Johnny, your $5 contribution is going to, get them vaccines for so and so. That's all important, but finding a way to get governments to come together and make sure that they contribute to surgery is not easy. So one of the things that we did was we spoke to the major players in the global health space, the Global Fund, Gavi Vaccine Alliance, Global Financing Facility, and said, what have you done that has worked in terms of like raising large amounts of funding to be able to address the needs that we have in the world? I can't go into all the details, but one of the things that they all mentioned was underscoring the importance of public-private partnerships, because you can't get anything done really without political will. At the end of the day, you need governments on board. You need governments with skin in the game where they invest their own funds, because that's what gets the wheels turning. But the governments cannot do it by themselves. You also need private individuals who make this their life's purpose, where they say, we're going to make sure that we push this to completion. So this is just a picture from last summer. We were in Geneva for the World Health Assembly. And we got to host several delegates from countries. And, that was, another one of the highlights of my experience, not because it's Geneva and Switzerland, but, because I think the work that we did was very important. So I have a couple pictures of various faculty members I've worked with throughout the years from my time before Penn, during Penn at Harvard. And all of these people have contributed to my education, and all of these people value capacity building, value relationships with local partners. And these are the kinds of people that I hope to become as I go on in my career. I also can't end this without thanking my family. I literally would not be here without them. And I think that a lot of the sort of values that I have really come from them. For me, global health work is about seeking justice. It's about pursuing equity. This is a wall hanging I have in my living room. And this portion, act justly, is something that I hope will continue to drive me as a clinician, making sure that you're seeking the best for your patients, wherever they are, wherever they're coming from. At the end of the day, bridging that gap is about seeking justice in this world. Thank you.
Well, sometimes, as Papa mentioned, surgery does get overlooked, but it is a very, very important area. And I have to say the student groups in particular at Penn have done an amazing job of helping to galvanize that community. And Papa's been a big part of that. And we run a symposia every fall, and it's always a treat to go. And last fall, some of you may remember, we highlighted our work in Ukraine, which is largely orthoplastics and other related work. So it's a pleasure to introduce the winner of the Lewinter-Suskind Faculty Global Health Award, Harsha Thirumurthy. And Harsha is a professor in the Department of Medical Ethics and Health Policy. For most of the folks in this audience, and many of whom of course know Harsha, this seems pretty normal to have someone who's basically trained as an economist working in global health. But for most other people, that's like, say what? Because Penn actually has a really nice tradition of people working between, not necessarily in the global space, but between health and healthcare. And I'm going to say the social sciences and behavioral sciences, of which I've always viewed economics as a fundamental part, because it's so much guided by our behaviors. I assume, as a non-economist, that's a fair comment. And Harsha has taken that to the max by taking the concepts that have been applied in settings often here and through his training, and applied these in really, really unique ways in global settings. So Harsha, congratulations and welcome.
I hope everyone can see these slides on Zoom as well. Thank you. Thanks so much once again. And really delighted to have this opportunity to share some remarks about my journey in global health and the work I've done. And before I get started with that, I want to first extend a huge thank you to you, Leslie, and to you, Bob, for the support you've demonstrated for global health over the years at Penn, and also obviously outside of Penn as well in the careers and experiences you've had. Tremendously grateful for that, and also I just think it's an incredible model for many of us who are earlier in our careers to follow. Also want to thank Glenn and Megan and the rest of the team at the Center for Global Health for all of the efforts you've made to raise the profile of global health research at Penn Medicine and beyond. And since coming to Penn in 2017, I've really benefited greatly from the number of interactions and exchanges we've had over the years. Some more thank yous. I came to Penn as a faculty member in the Department of Medical Ethics and Health Policy, and the division chief for health policy at the time, Kevin Volpe, played a big role in recruiting me to Penn, but also so did many of the other faculty members and the rest of the leadership team in the department. So I want to especially acknowledge Steve Jaffe's support for not only my work, but also for global health research in general in our department and beyond. And then I have some more thank yous that I'm gonna scatter through the talk, and you'll see. So let me get started. And I was really really touched by some of the stories you shared earlier, and I hope the title, which before I heard the stories, I'd prepared the title, but I think the title in some ways reflects my belief as well that the borders we have between countries should not be barriers of all kinds, including in the research realm, including in the realm of how we choose to allocate our resources. And you'll see that has been a core value in my work, is to really take the point that all lives have equal value seriously, and to devote attention to some of the problems in the realm of health in low and middle income countries. I noticed there's some wine on the side there, so I figured if I can get through my talk quickly, then some of us can partake in the wine drinking, and also that I could have more conversations with those of you who've made the time to be here. So I will try to march through this agenda for my talk. Just give you a little bit of background in how it is that I ended up here. As Glenn pointed out, you don't often see economists in medical schools, especially working on global health. And so I will explain that part, share a few insights from the research I've done over the years, and then close with some broader points about where I feel this work is headed, and the opportunities and the rewards that come from doing this work in global health. So, long story short, I was born in India, and if it wasn't for the decision that my parents made to come to the U.S. when I was about 12 years old, I may not have ended up in this journey of doing research in global health. Because I was born in India and moved to the U.S. at an early and influential age, I was very interested in the vast disparities in living standards between countries in the world. In the 80s, India was in a very different place, and still is, than the U.S. And so when I'd finished my undergraduate degree and was contemplating different career paths, I was very interested in developing some of the skills and knowledge that would be required to understand the process of economic development. And I chose to go to a PhD program in economics at Yale, in part because there was a very strong tradition of development economics research there. Development economics is a field within economics that focuses on low and middle income countries specifically. Yale had an economic growth center, which was established in the 50s and 60s, and some of the seminal work in economic development happened there, and had incredible mentoring and incredible colleagues there. But as often happens, I'm also got distracted by some other things. And one of the things that was happening at Yale at the time, and this is in the early 2000s, is Yale had the patent for one of the crucial antiretroviral drugs that are used to treat HIV. And there was a student campaign to make this medicine more accessible in low and middle income countries, especially in Africa, where the burden of HIV was the greatest. And so as part of a student campaign to essentially liberalize sort of the access to this important antiretroviral drug, that was really the first time I became extremely interested in health specifically. I went to Yale thinking I was going to study labor markets or agriculture in low-income countries, but instead became interested in health because of all this work that I was doing in the realm of HIV. And of course, I couldn't get a PhD in economics just for advocating for access to medicines. I had to pick a very focused topic area. And I noticed that HIV treatment was becoming available in some countries in Africa in the early 2000s. So I'm giving away to some degree my age here, but I did manage to cobble together some funds to go to Kenya and work on a project there that would study the economic lives of people who were among the first people to be getting HIV treatment in Africa. Now, some people who know me well know that I'm really passionate about running. I've been a distance runner pretty much since high school, and so you'll be perhaps intrigued by the choice of research sites that I made. I went to a town called Iten, which happens to be like the epicenter for distance running in the world. I did not choose this town because of my interest in running, and I kid you not, sincerely, I chose it because there happened to be an HIV treatment program that was the first program in Africa to provide rural HIV care in rural areas. But a nice perk of doing my research in this town in Kenya is that I got to run with some of the best and most famous runners in the world. This photo, which shows me at the youthful age of like early 20s, I think, has not one, not two, but three Boston Marathon champions in it. And I had the privilege of running with them one very memorable day. But the real reason I went there was to do research in partnership with a program called AMPATH, which set up an HIV treatment program in rural Kenya. And this was in 2003, just before the US government's presidential emergency plan for AIDS relief was introduced. So I got to do some research there, and I'll tell you more about that in a few minutes. After finishing my PhD, I went to the UNC Gilling School of Public Health, Global Public Health, in part because I was very interested in doing interdisciplinary work that allowed me to collaborate more closely with healthcare professionals, physicians, scientists, et cetera. And I had 10 wonderful years there at UNC before moving to Penn. And one of the reasons I moved to Penn is that there are a number of, as Glenn hinted at, there are many people who have been very successful at building a bridge between the social sciences and health and healthcare policy at Penn. I just want to acknowledge some of the people that played a big role in my decision to come here. Jerry Behrman, I see from the economics department, really was one of the pioneers in applying economics to health in low-income countries. People like Alison Buttenheim, David Ash, who've done a lot of applied work over the years. And also many of my colleagues in the department that I've been in for the last 7 years also played a big role in my decision to come here. So I want to give you a summary of some key research studies, research insights that have come out of the work I've done over the past 20 years. And I will try to focus on a few studies in each of the core research areas. These are some of the principles that have been really central in my work. When choosing what to work on, I've often gravitated towards research questions that have an implication for healthcare policy in low-income countries. I haven't been wedded to any one particular methodology. We've used experimental methods, so randomized trials, but we've also done a number of studies using non-experimental methods. And as I hope you'll see in the studies I highlight, there's been a big emphasis on including local researchers and local experts in the work we do, because I think there's so much that can be learned from all of the knowledge that they have. And I'll demonstrate very clearly for you examples of not just the traditional sort of model that tends to prevail, which is of researchers from the global north who have more resources, who have the more advanced training, bringing their skills to low-income countries in the global south, but also vice versa, where we've seen very concrete examples of the learning going the other way. Two key research topics, actually some of them were highlighted in Papa's remarks as well. My research has been really focused, especially early on, in demonstrating the returns to investing in health. And I'll show you what those returns are in a couple of studies. And then more recently, I've been focused on economic and behavioral interventions that can complement healthcare service delivery and ultimately be used to promote health. So this is the research project that came out of that first trip to Kenya that I made. I lived there for 2 years collecting data from people who are receiving care at these clinics. Using the medical records that the clinics maintained, we showed that when people who had HIV came to these clinics and started receiving HIV treatment, their healthcare outcomes improved, their health outcomes improved tremendously. So here you look at the body mass index, it's declining quite substantially and is at very low levels before they initiate HIV treatment. And you see this very rapid rebound in their health. It's very well known to people who work in HIV. We just simply confirmed that with the medical records. As an economist, what I brought to the table here was essentially an ability to measure some of the economic characteristics of participants and to document what happens to their economic outcomes. And so here we're just looking at a very simple marker of, are they engaged in the labor force? This is mostly individuals who work in rural areas, so they're working on their farm or they're running a small business. And their participation in the labor force also essentially rebounds very rapidly and mirrors the response in their health outcomes. So sort of one of the early indications in 2003, 2004 that investing in HIV treatment also yielded a lot of substantial economic benefits. And in fact, this work has played a role in some of the policy discussions around how much investment should be made by rich countries in HIV treatment. Even as recently as March of this year, there were debates in Congress about whether PEPFAR, the US government program, would get reauthorized. The good news is it was reauthorized. The bad news is that it was only reauthorized for 1 year, so we're going to be having this debate again next year. But nonetheless, this program, PEPFAR, has contributed to many millions of people receiving HIV treatment over the years. And the evidence from this work, as well as other research that's been done since then, suggests that it's contributed to these economies remaining vibrant despite this raging pandemic. Another example of demonstrating returns to investing in health, this one hopefully will appease those of you who think it's very crude to focus only on the economic outcomes. That's obviously not why we should be investing in health first and foremost. So here we're looking at health outcomes that we really care about, child mortality. And we focused on the President's Malaria Initiative, which was started in 2006. And the PMI, as this program is known, has supported malaria prevention and treatment activities in over 19 countries in Africa since it was started, and currently has an operating budget of about $700 million. Malaria, we all know, is a leading killer of children, in particular in Africa. Over 600,000 deaths per year attributed to malaria each year. This study that I did with a former student of mine at UNC and published in PLOS Medicine essentially looked at what happens to mortality rates, child mortality rates, as well as other indicators of malaria treatment and prevention coverage in countries that benefited from PMI support. We used a methodology known as difference in differences, so a non-experimental methodology to attribute an effect to the PMI program, showed that there was essentially a 16% annual risk reduction in child mortality rates due to this investment in PMI. And when I spoke to a reporter about the study, a reporter was considering reporting on it, he said, well, I can't say that the headline is 16% reduction. I need to know number of lives saved. And so we went, even though it was not published, we did some additional calculations and showed that the number was 2 million. So there were 2 million children who would have died were it not for this program having been implemented. And that 2 million number, sure enough, this reporter was right that the number really sticks with people, including Bill Gates, who referenced this study as part of his effort to essentially advocate for funding in global health. Briefly want to tell you about work I've done on the side of interventions to promote health. A number of my research projects have used randomized trial methods to figure out how we can increase the usage of HIV services. One of the lessons from behavioral science is that even when health services are made available, even when we do overcome some of the barriers to care, the very concrete barriers like transportation costs, et cetera, people may still not utilize these services because there are other barriers that they're facing. They could be behavioral in nature, they could be economic in nature. And so in Zimbabwe, we worked with an organization called PSI, Population Services International, to help them figure out their policy on how to subsidize and how much to subsidize HIV test kits. These are home-based HIV test kits. And we documented in this randomized trial that essentially, if they charge money for these test kits in very resource-limited settings, so if they have what's known as user fees for these tests and these services, the demand for the services is going to plummet to zero, okay? So in this experiment, essentially what we see is that when you charge people something like $3 for these test kits, almost nobody uses these tests, but even when you charge 50 cents, demand is very low. And when you offer them for free, the demand increases substantially. And this has been a key lesson in a lot of the global health work, is that user fees often can be very detrimental to demand. Seen that for bed nets. We've now seen this for HIV tests as well. Another study, we worked with the Ministry of Health in Kenya, the US government's HIV plan, PEPFAR, to do a randomized trial of transportation and food vouchers to promote uptake of medical male circumcision. Again, an HIV prevention service that results in 60% reduction of HIV risk, HIV acquisition risk among men, and showed that, again, if you offer some sort of compensation to address the barriers that people face, you can see dramatic increases in demand for these services. This is the type of work that ultimately, yes, it results in research papers being published in journals, but also is contributing to policy because the policymakers are looking for evidence in these cases as to whether or not to offer subsidies, whether or not to offer transportation vouchers. So let's see. Okay. Last study I want to tell you about, it has to do with not just low-cost interventions like incentives or small subsidies, but much more substantial interventions that seek to alleviate poverty altogether. One way to do that is to offer people cash that essentially lifts them out of poverty. Many countries have introduced cash transfer programs. A number of cities in the US are considering these types of guaranteed income programs. But in resource-limited settings especially, we're fortunate to have a number of governments that have scaled up cash transfer programs. And along with an assistant professor at Penn who works a lot in global health, Aaron Richterman, we did a study comparing countries that have introduced cash transfer programs to countries that don't have such programs, again, using a non-experimental difference in differences methodology. And we showed in this study that there was a 20% relative reduction in the risk of death among adult females when cash transfer programs were introduced to alleviate poverty. And similarly, there was an 8% relative reduction in the risk of death among young children as well. So this is really striking evidence that alleviating poverty through cash transfers results in major improvements in health. And we're now using this study and other evidence we've generated to really conceive of a study that would test experimentally what effect these types of programs can have on HIV tuberculosis outcomes in high burden settings. I want to conclude by just telling you about some of the rewards to doing this work. They're both on a personal level as well as professional and beyond. The study we did on medical male circumcision was the first study that I did with an organization in Kenya known as Impact Research and Development Organization. IRDO is led by a medical epidemiologist who essentially runs, it's a very grassroots NGO, has delivered HIV services and other health services over the years. We've had a team there now for over 12 years that's been doing a number of studies. And in each of these studies, we've tackled questions that the Kenyan policymakers, that the WHO is very interested in. We've learned a lot from research projects we've done together over the years. Many of the ideas for the research projects actually come from our Kenyan research assistants, our Kenyan colleagues. Give you one example, which is HIV self-test kits. These are oral fluid-based swabs. Our Kenyan research assistants, one day when the test kit was approved by the WHO, we were talking about these test kits, and they said, you know, I'd love to be able to give these test kits to women and see if they can offer the test kits to their male partners. And that was a study that was conceived of by our colleagues there. Ultimately did a study which was published in the Lancet HIV, had this beautiful illustration as well on the cover, but ended up informing the WHO guidelines. And even here in Philadelphia, there are organizations that have adopted this approach of distributing HIV self-test kits in the community. We saw lots of examples of that during COVID-19 as well, obviously. Another example of the learning going from the global south to the global north. This is a project I've been involved in with Alison Buttenheim and others, has to do with using visual aids to help people understand how treatment works in a person's body. So in South Africa, we were working with an organization that said, we're really struggling to explain to people the importance of taking your treatment regularly, to explain concepts such as transmission of HIV from a person living with HIV to a partner. And we came up with these bead bottles that essentially demonstrate what's happening in the body when a person has HIV and is not taking treatment. So you have the red beads, which are unhealthy cells or HIV, and the black beads, which represent healthy cells. And you have a lot of those red beads when you're not taking treatment. And when you take treatment, you don't cure HIV. There's still a red bead in that bottle on the right, but there's a lot less HIV and you're much less likely to transmit it. Did a study to show that it does increase treatment literacy among people living with HIV in South Africa, and then brought that evidence here to Philadelphia and used this same bead bottles in medical case management agencies that serve people with HIV here in the US. And have seen very promising results there as well. So a good example of an intervention that was developed in the global south that's being used here in the global north goes against how we typically see these types of translations going. Finally, I'll tell you about some of the achievements I'm most proud of. One is in 2020, the Gates Foundation, which had been following a lot of the work my colleagues and I had been doing in the space of behavioral science and HIV, came to me and said that they would love to support the development of some sort of initiative that would increase capacity in South Africa to apply behavioral science on a large scale. And I was very fortunate to have a very strong collaborator and partner in this work, Alison Buttenheim, who jumped at the opportunity to work with me and collaborate on launching this initiative together. So she and I co-founded INLAILA with partner organizations in South Africa at Wits University. And INLAILA's goal was to, number one, build capacity to apply behavioral science to the HIV epidemic. And number two, to support research projects that could be done rapidly in collaboration with local partners. And even though we had the misfortune of being funded to start this in 2020, January 2020, right before the pandemic, you know, it's really a remarkable testament to the efforts made by our South African partners that this initiative has really taken off despite the start in 2020. We've built a very strong team that's based in South Africa. We've supported them over the years, and last year we actually transitioned ownership of the Nudge Unit to Wits University. So they're now supported and they're leading this with our contribution on the side, really. And then finally, here at Penn, how have we tried to build and establish this work? so that it can grow over time and so that it can attract more people. As you said, you were the first to express an interest in global health. We want more and more people to be working with us in this area. So Allison and I established the Begin Lab last year as a way to really bring together this work that we're doing in the space of behavioral science and global health, focusing again on many of the health conditions that matter the most in low-income settings, being very inclusive in our research programs and research projects, and then prioritizing dissemination of this work to local policymakers. We have a number of projects, I'm pleased to say, that are ongoing right now, supported by the National Institutes of Health, the Gates Foundation, and we're tackling issues that are both related to HIV, but we're also branching out to other topic areas such as misinformation, as well as non-communicable diseases in India. So that is going to bring me to the end of my talk. Here's a photo of our Begin Lab team. I should say that this team has been instrumental in the work we do. 3 of them are actually in Kenya right now, and they're working on our projects there, and I'll be joining them next week. So thank you.
First,
you.
it's very heavy, by the way.
I've been
Here we go.
warned. All right.
Ready?
Yes. Thank you.
So, any questions?
I say bravo to you. And I think that one of the travesties of this planet is that we divide ourselves up and divide ourselves up. It's wonderful that you're going over there and helping, but this is the way it should be, that everybody working together to solve a problem. So to you, bravo. To the rest of the world, okay. Bravo.
Thank you so much.
One of the things that Harsha and I have spoken about, something I see a lot of, and you know, he's aware of this and you see this in his work, is as academicians, we often tend to focus on that, you know, the academic part, how to get the paper out, how to do the research. And I can't tell you the number of times I've had faculty, you know, students, others come to me and say, well, I did this work, but then nothing happened. And I think Harsha's shown in part how to do that, but I also wanted to ask you, what do you think are the clues to ensuring? You mentioned a couple indirectly, but maybe we could hit it directly. What are the clues for others about how you can, you know, prepare the way you're designing and thinking about projects so that they can be implemented in a way that's sustainable in terms of actually changing, not just policy, but implementation?
Yeah, I mean, it's a great question. And I'll say, you know, first of all, continue to learn a lot from many of my colleagues at Penn who are doing this work really well. You're thinking about Christina and her work in strategic science, and David and Allison as well. I think one of the keys, Glenn, is to start engaging the policymakers in a conversation early on. That was something we did really well in Layla, as we engaged the implementing organizations and said, what are the challenges you're facing? What are the solutions that you would consider ever implementing, even if they were successful? So that's one, is just finding ways to either get a seat at that table or to just engage the policymaker or the program in a conversation. I think the other is to be thinking about on the funding side as well. You know, what is the appetite for this type of this work? So we're doing a lot of that with the Gates Foundation, thinking about what is the types of interventions they would ever consider supporting as well. Those are some keys.
I did learn something in addition to, you know, few scientific things, that Bill Gates has to actually ask for funding. Say that in your thing.
Yes,
You
that's
wouldn't
right.
think, you know. Anyway, any other questions? I think we're pretty much up against it. Okay, well, thank you again, Harsha. Thank you, Papa.